Okay. So the first outbreak was only investigated so that they knew the numbers of cases, and that was about it, and maybe age distribution. So now, some years later, there was another outbreak, and after a certain period of time, it became bigger, and we were called in to help. The case finding showed that we had about 74 reported cases. Do you remember? Reported means this is the tip of the iceberg. There are probably many more, but as we know, also for corona. So at least 74 of those cases were reported to us. 47 were confirmed cases. The others were cases which were related to this. At least we didn't have serological confirmation, but most of them were confirmed. More than half were male, and the mean age was 42 years of age. Minimum 12, maximum 78 years. So wide range. Okay, and here again you see the epidemic curve from before. What kind of transmission route could it be with this Q fever outbreak?
Common source.
Very good, very good. Aida, you wanted to add something?
Yeah, it is like for Q fever in particular, there are many ways of routes of transmission, through ingestion or through inhalation. That's and one of the main dangers of it, that a single microbe could do harm to a patient, and also some are asymptomatic and some are severely affected.
Absolutely.
And I just want to add like a comment about the X-rays.
Yes,
so
I just thought like I should have asked you to tell us about the X-ray, because you're the expert on this.
If you would like, I'll comment on the, yes, please. So in general, even in corona, in asymptomatic patients, even in Q fever, you'll see the same normal X-ray in asymptomatic.
Okay.
The other X-ray, it's a complicated pneumonia, whatever the causative agents, Q fever or even flu, or even if certain patients with COVID could have complicated pneumonia with the same picture. The white area, the difference in the A and B, it's filled with pus and fluid, so there is no air. The above you can see air in this, while the other is filled, obstructed, no air intake. So this is exactly, it's a complicated case of pneumonia, which could you'll find the same picture of could be right lung, left lung, upper part, lower part, but it's not specified for Q fever. For COVID in particular, it has its own pattern. When this is the good thing in COVID, like especially for CT scan, it has its own pattern. So many times physicians start a treatment before the result of the PCR.
Okay, and because this part here which is filled with fluid and so on, and even this is a bit grayer than the normal,
exactly.
than the other side. So practically exactly. the right lung is almost non-functioning in this patient at this time, isn't it?
The middle and lower lobe are non-functioning. The upper lobe is functioning. It is divided to three.
Good. Thank you. Yeah, I just wanted to show that, and you're also pointing on an important factor. It's like always, not all cases are symptomatic. We have lots of asymptomatic. That's why I meant that we have 74 reported cases, and the reported are normally the symptomatic ones. And there are probably hundreds out there in the community of which we didn't get to know because they were asymptomatic or not very symptomatic. and they would not be diagnosed. Absolutely right. Exactly. And here we see there was a common source over a longer period of time. And the geographical distribution here shows this is one neighborhood of this city in the far east of Dortmund. And one of the most of the cases are located around this area, some outliers, but most around this area. And in the middle, there's a farm. So, and Aida also pointed out, and that's very important as well to mention, there are many ways of transmitting this Q fever. It could be, yeah, as she said, and in addition, it could also be tick-borne. Also, ticks can transmit this pathogen in an area. So we really had a problem here, a reoccurring problem. An outbreak like this occurred some years before as well. If you don't investigate, as I told you, an outbreak, an epidemic will eventually stop. But if you don't change anything, it will come back again. Why will it come back again, or when will it come back again? We also discussed before, when the number of susceptibles is high enough, and a new introduction of the pathogen will take place as a zoonosis. There are often opportunities for introduction of a pathogen, so it's only a question of time. That's why we decided at that time, okay, this is not only an outbreak, we know it will eventually disappear, but if we don't find the source, we will never be able to change something on the situation, and this neighborhood will see outbreaks coming and coming and coming. Okay. Oh yeah, the age and the gender distribution, I told you it's a big wide distribution of ages, and both gender are affected. Okay. Based on the descriptive epidemiology, the next step would be to generate a hypothesis. And you need to take lots of those factors into account. The descriptive epidemiology plus a clinical picture plus the local situation which is given to you. Why do we now have to develop a hypothesis? Because we are humans, with other words. Immanuel Kant, a famous philosopher, once wrote this in German. I'll just refer to the English translation. When we experience that something happens, we assume that something preceded, as it will follow a rule. When we see something happen, we normally think there must be a reason for this. And we thinking about potential reasoning for it, we are practically developing our personal hypothesis. This is what we as humans always do. So based on what Aida also said, that there are many potential ways how people could get infected here, we looked at different transmission routes. One of our hypotheses was it could be contact to sheep feces or contact to infected sheep in general. That was our idea, because sheep are often the host for this pathogen. We also had some additional facts for this, namely, we had results from the veterinary office about the seroprevalence of antibodies against this Q fever among sheep in the neighborhood. It was called Assern. In the neighborhood, it was much higher than further away from this region. You can see it's not uncommon for sheep, but in this region it was very, very common. So maybe it has something to do with the sheep. There's some idea. We also were wondering about contact to infected other animals, or infected milk or raw milk consumption, for example, could also lead to this, or tick bites. Okay, so it could be a multitude of ways, and we wanted to identify the source. So how would you go about this? You would probably want to test your hypothesis, probably with an analytical epidemiological study. and preferably to confirm it with laboratory methods. Okay. How would you do it? What would you have done? Jennifer, please. Jennifer? Or maybe, okay, maybe Ibumita, you start. I think Jennifer's connection is coming and going.
Can I go?
First, you start.
Okay, so you have to take the sheep feces itself and test it. That's how you can test your hypothesis. You take because now we have hypothesis of where the transmission can come. So we take the sheep feces and we test for those antigens in the serology of the stand. We also test milk from that particular area too. We test those that come in contact with the sheep in that particular area if they have this infection itself, and if there is a possibility that there's an epidemic in that particular area too. Yeah, and if other animals that are close to these infected sheep, if they also have it, and that's where I think that's how you can test the hypothesis.
This is a possible approach, and Ibumita, I must tell you, you are very traditional German, because this is how most of the people in that field in Germany always used to work. And it's useful, no doubt about that. The question I only have is, like, if you find traces of the pathogen in the sheep, in the milk, or whatever, does it mean that the people got ill? Standing alone, this information is interesting, but it's not linking to the people who are ill. Maybe I would suggest, maybe we think about to do what you suggested, Ibumida, but we also do an epidemiological study to see whether the cases are linked somehow to the disease. Jennifer, you were the, what you do is,
It's not off, it's just not working. Oh, it's on now.
yes.
Sorry. I was mentioning that as an epidemiologist, yes, the lab diagnosis is good, but I would carry out a case control study. Look at the cases and find out information about exposure, where were they, what exactly is happening, the risk factors around them.
Yeah, the combination of both is probably very good. Mian, would you have agree with the case control study, or why not a cohort study?
I would start with the case control because the cases are already identified, and I would look at the patterns, how they were exposed, what characteristics they had, and would it be related to the job or something else? Yeah, so I would choose case control.
What did the others think? Why not a cohort study? You are right, but why? Hatem, what do you think?
I think also because it's as Mayan and Jennifer mentioned, like we are going retrospectively, we have the cases, we have already the outcome. It's not calculating a risk, or like we have.
This one is working.
The cause.
Yes, yeah, that's a good reason. And Jennifer, you wanted to add something?
I think, as agreeing with Hatem, a cohort study would take a long time, and yet we need to have an intervention as fast as possible. So then we first do the cohort study, implement whatever interventions we can implement, and then we can continue with a cohort study with time or later.
Okay, if Yinva?
Yeah, I agree with Hatem. I agree with her.
Okay, and Aida?
In Q fever, we have multiple routes of exposure. So it would be difficult to perform a cohort study with multiple exposures, while in control it's easier.
Yes, and it would probably also not be ethically acceptable to wait another to continue for some time while you've got 74 confirmed cases, and as we know, probably several hundred people affected by the disease in this neighborhood. Okay, absolutely agree. So case control study, retrospective nature, we have the cases, we now have to find the appropriate controls, and then we can ask them about their exposure history. Apropos controls, who would you take then as controls? I agree with you, this is the right study design. There's also the reason you cannot even do a historical cohort study, because the people are spread all over the neighborhood. So absolutely this study design. But the problem, the results of a case control study stand and fall with your decision. Like, what are going to be the controls? How would you have chosen controls? Good question, isn't it? It's a tough question also. Jennifer, please, you were first. It's off again, unfortunately. Yeah, we can hear you. We can hear you.
Okay, based on the cases, then I would look around the population that is in close relation to where the cases are.
Okay.
Determine my controls or my population at risk.
Okay. Atem, what do you suggest?
Yeah, I think like I agree with Jennifer. Plus, like we would like people in close contact, plus people with similar circumstance, like predisposing factor like age or things like that.
Yeah.
Yeah, I think so.
Okay, Mian.
I agree with Hatem and Jennifer. It would be good also to look at other to sort of match the populations.
Yes, if we're not going to introduce any limitations, if we match, for example, for the factors we match, we cannot analyze later on.
No.
That's the problem with matching.
Yeah.
Yes.
Yeah. Okay, Aida, you wanted to say something?
Is it because, as the example, sir, you gave it earlier, that we don't know if they are still within the incubation period of the disease? So would it be like we choose like if they were in the same area, that like after 2 weeks, or from the exposure, or in another area not exposed to the disease?
I think you're raising an important question. In a case control study, the controls should have not the same disease, but they should have been exposed to the same area. But if Yinva obviously wants to say that.
I wanted to say that I thought the control are going to be the healthy people in the population that may be suffering from other diseases, but not the exact study you're trying to work with. That's what I thought the control would be.
Right, and but the controls should have been exposed to the same thing, should have had the opportunity to have been exposed to the same area, to the same factors, risk factors. So therefore, okay, it's a very important point. It's like, I would highly recommend that the people, they should come from the same neighborhood, more or less. If you take them from Hamburg as controls, they could have done, again, whatever they liked, but they could have been bitten by hundreds of ticks at the same time. If there was no Q fever up in Hamburg, it wouldn't help us. So they have to come from the same neighborhood and have to be similar somehow, isn't it? Aida, you want to comment on this?
Can we do like serological tests
We could also do serological testing.
and
The
see
question
if
would be if all the controls would be happy to give blood at the same time. That's also because it's you always have to weigh better. It's better if you test them. You're absolutely right. But the question is, will they be happy and will you not get selection bias? Only select those who have a high interest in the study to participate so that they come to your office, or even if you send somebody out that they give blood, they are maybe not representative anymore because they are highly motivated. So you're gaining something while you're losing something. You're gaining more precision while you're losing representativity for the population. So it's always, there's no black and white in the whole situation. There's no perfect study after all. And we have little time because we have this outbreak investigation. We've got lots of people there and you need to come to an answer. And as we saw, 74 people got obviously symptomatically ill, and you don't know if people are going to get seriously ill and die. Can happen. So we need to move fast. But Karine wants to say something.
Okay, could it be that when we're choosing our controls within the population, we're going to look at the number of cases, the area with which they live, especially if they're exposed to the risk factors, which is like those living around the farm where you can, or people that walk around there. I mean, since we said that it comes from the sheep, which is,
We assume that these factors play a role. And therefore, let me just to sum up at this point, we choose to look for a random sample of people from the whole area, because in Germany you've got everybody has to be registered with the local authorities. So we ask the local authorities to send out our questionnaires to a random sample, but drawn by chance from the same neighborhood. So only people from the area who could have had whatever exposure it might be, and who would be representative for the whole population, so that we can compare what is different in those ones who got ill to the general population. Okay. Yes, one moment, please. Okay, so that's what we did. Let's make a short break because I see there's one request where your cooperation is needed. Let's just stop. Let's stop for a short while and let's